Director of Genea and the Chief Medical Officer of Genea Biomedx. And likewise, the Global Fertility Alliance is a non-profit collaboration between Merck, Illumina, Hamilton Thorne, Zeiss and Genea Biomedx. And tonight I intend to give you the rationale for its establishment and beyond that, the context, both clinical and scientific, for the reasoning behind its aims and goals. I think I need the slide. There we go. Oh, yeah. The Global Fertility Alliance's mission is advancing fertility treatment excellence through innovation, standardisation and education in order to advance global best practice that will benefit all doctors, scientists, nurses, clinics and above all, of paramount importance, our patients. Now, some time ago, probably a week or two ago rather, I received an email from ESHRE, and I'm sure most of you would have as well, asking me to download the ESHRE app. And within that app there were hundreds of lectures, presentations, abstracts, which represent the pinnacle of our discipline. The thing that it didn't represent was the cross-section of our processes and our results from one end to the other. So it was leaders in the field presenting high-quality research, but not the spectrum of all practices that we see today. Now, around the world there are currently about 4,500 clinics undertaking just under 2 million cycles annually. And there is a massive variation in IVF utilisation, assisted reproductive treatment utilisation from region to region. For example, if we compare the per head utilisation of IVF in Europe to Australia, the current 580,000 cycles annually would be 3 million cycles annually. And if that were true of China, that would be 8.8 million cycles annually. So you can see the massive potential for growth of our field over the coming years, assuming that the communities in those areas adopt IVF and assisted reproductive treatments and increasing orders of magnitude over time. And with the advancement of our technologies and the improvement in results over time, that is likely to occur. Back in 2012, Jacques Cohen, who some, if not many of you will know, a preeminent embryologist from the United States, made the insightful and indeed somewhat emphatic statement that the ultimate goal of IVF is to achieve healthy, single live births following each single embryo transfer. And probably a decade or so ago, I had the enlightenment that moving from transferring 2 embryos at a time to 1 embryo at a time could provide at least the same live, healthy baby rate as transferring multiple embryos by avoiding twin pregnancies and high-order triplet, quadruplet pregnancies, and simultaneously reducing perinatal mortality and morbidity by factors between 3 and 6. So a dramatic improvement in the health of those infants. Now, this table, graph, represents data from the Australian and New Zealand assisted reproductive database. And in those countries, we're lucky to have all IVF cycles recorded annually, and about 18 months after the end of the calendar year in which those cycles are completed, we're able to aggregate the live healthy and, for that matter, live unhealthy babies from those 2 countries. And you see here the cascade of results or cascade of treatment between initiated cycles down to egg collections, embryo transfers, clinical pregnancies, and then live deliveries. And in that year in those countries, the clinical pregnancy rate per embryo transfer was 30.8%. However, the live birth per initiated cycle was 16.3%, so just over half what we, at least myself as a clinician, would represent as a result. But from a patient's perspective, live births, the treatment started, is far more important than clinical pregnancy per embryo transfer. So the patient's aim is to have safe, simple, affordable, efficient, predictable, and indeed reliable treatment. Now, to illustrate that point, there is marked region-to-region variation around the planet between, in this case, the United States, Europe and Japan. I wouldn't jump to conclusions because there are strong cultural, clinical practice, social and indeed funding envelope reasons for much of this variation. But beyond that, there are indeed unexplained scientific components which as yet remain questionable, which require further examination and analysis. And this table, once again from the Australian and New Zealand data, illustrates the point with regard to pregnancies. What we have in the rows is patients separated by age, and in the columns, the first column is aggregate, and the next four are first, second, third and fourth quartile of clinics. And what I'd like to point out is that the top of the first quartile is indeed the best clinic in that age group, or the aggregate, and the figure on the bottom of the fourth quartile was the clinic that achieved the lowest results. At an aggregate level, there was a threefold difference between the best clinic and the clinic that achieved the lowest results. And in some subgroups, in particular, the patients over 40, where the best clinics tend to excel, there was in fact a 12-fold difference between the clinic that achieved the best results and the clinic that achieved the lowest results. So are we reliable? I think, at least from the information presented here, that answer is self-evident. We're highly variable. And the variation just presented with these simple tables is repeated in international registries from Canada, the United States, the United Kingdom, and to the extent that we can assess it, in Europe as well. Now, to make a banal and simplistic statement, 49.9% of all clinics achieve results that are less than average. And that means about 2,250 clinics undertaking about 1 million cycles annually lead to results that are subpar, suboptimal and sub-average. So we need to ask ourselves the question, is there room to improve? There must be. Indeed. We've got the answer already, because of your call. Is there room to improve? To me, that's self-evident, and it needs interrogation and determination in order to move in that direction. We know the key to improvement lies within the laboratory and the technologies that we use within the laboratory. At least 2/3 of the degradation between initiated cycles and live births occurs in the domain of the IVF laboratory and the components that are influenced by it. And around the world, if you go into different IVF labs, as I have, many of you here do on a regular basis, it's self-evident why there might be variation in outcomes. In accommodation, structure of the building, the equipment, the processes, the ratios of staff to patients, whether you can smell the outside environment within the lab in itself. And it is, even at a most cursory inspection, fairly easy to imagine why one lab might produce results that are 3 or for that matter 12 times better than another lab. And so there's high variability from region to region and high variability from country to country. Now, I don't want you to read this slide. What it represents is a list of processes which were identified when Genea's fertility clinics went through a process mapping exercise to define those components which will have and do have an influence on outcomes in assisted reproductive treatments. And importantly, each of these processes has a set of variables. In some instances, that's 5, 10, 15, 20 different variables. And so the variability in outcome increases almost exponentially with the number of processes. And controlling the number of processes via standardisation, one of the key aims of the Global Fertility Alliance, has a marked beneficial effect on the potential outcomes for our patients. So a path forward, just one of many, to maximise the probability of live, healthy babies for our patients is to focus on eliminating highly variable processes through innovative technologies that enable standardisation and a restriction of that list, a compaction of that long list that I gave you before. And so these goals are reflected, these aims are reflected in the goals of the Alliance, using clinical and scientific insights to inform intelligent research that then leads to the development of technologies which enable standardisation, and then with that achieve at least an outline of global best practice which enables us to educate our colleagues around the world, particularly those clinics that had at this point fitted into the 49.9% to improve the outcomes for all our patients.